Her topic is Biomarkers in CKD-MBD, Dr. Jyothipriya. To the AV team.
Biomarkers.
Yes, okay.
Good afternoon. My topic is on hyperparathyroidism, biomarkers and recognition. We all know CKD-MBD, as told by my previous speakers. It is characterized by three major abnormalities: biochemical abnormalities, bone abnormalities, and vascular calcification. We know there are various abnormalities happening in CKD, starting with increasing in FGF23, increased PTH, decreased clotho, decreased vitamin D, and all these changes culminating in renal osteodystrophy and vascular calcification. And you can see in this slide, as CKD stage advances, all these changes become more pronounced. Now, there is a complex interrelation between all these factors, resulting in severe parathyroid gland hyperplasia. Now, coming to clinical manifestation, in the bone, we have subperiosteal bone resorption. In the spine, we have Rugger Jersey spine, cystic bone lesions. And here we can see the skull showing salt and pepper appearance. And on the right side, we can see severe subperiosteal reabsorption in the middle phalanx. And we also can have soft tissue calcification in hyperparathyroidism. Now, coming to tertiary hyperparathyroidism, there is a marked elevation of PTH caused by severe parathyroid hyperplasia, and this condition ultimately requires parathyroidectomy. Now, coming to the diagnosis of CKD-MBD, it is based on serial evaluation of parameters of mineral metabolism, bone histology, and radiological evaluation of vascular calcification. Bone biopsy, though it is the gold standard, it is not routinely performed. Instead, we use the biomarkers. We measure the serum PTH, calcium, phosphorus, vitamin D, and bone ALP. We know the role of FGF23 in controlling the phosphorus balance. Studies have shown FGF23 is an earlier and more sensitive marker of disordered mineral metabolism and even superior to PTH. And we know the role of clotho acting as cofactor in the activation of FGF23. So, clotho expression declines in early CKD and then progressively with declining EGFR. We have assays for both clotho as well as FGF23, but not used clinically because of high cost and standardization issues. Now, coming to the bone biomarkers, we have bone formation markers like procollagen type 1 amino-terminal propeptide, osteocalcin, bone ALP, and resorption markers like hydroxyproline, hydroxylysine, CTX, TRAP5B. Majority of these markers are cleared by kidney. So, in CKD, it is better to go for markers like bone ALP, P1NP, and TRAP5B, which have no renal clearance. Now, these are the biomarkers we have. And of that, we have PTH, bone ALP, bone formation markers and resorption markers, and the newer marker, sclerostin. Coming to our main biomarker, parathyroid hormone, it is regarded as the best available biomarker for detecting MBD. Now, PTH is synthesized as a 115 amino acid pre-pro-PTH. It is cleaved into pro-PTH with 90 amino acid and then to active form PTH with 84 amino acid. And it has a very short half-life of 2 to 4 minutes, and it is taken by the liver and degraded into active amino fragments and inactive carboxyl fragments. And if you take the total PTH in the circulation, around 30% is the intact PTH, whereas the majority is the C-terminal fragment. Now, coming to PTH fragments, in CKD, what happens is this PTH, C-PTH, which is biologically inactive, it is cleared by the kidney. So, there is accumulation of inactive C-PTH in renal failure, and the non-PTH 1 to 84 fragment is a subset of large C-terminal fragment. It is measured by intact PTH assay. The predominant isoform is PTH 7 to 84, but the problem is it has an action opposite to the active PTH, and it has inefficient binding to PTH receptors. So, this fragment accumulate in CKD, and this contribute to the skeletal resistance we observe in renal failure. Now, coming to the modified forms of PTH, we have several forms like oxidized PTH, phosphorylated PTH, amino PTH, N-terminal PTH. Of that, the important one in CKD is oxidized PTH, because in advanced CKD, there is huge oxidative stress. So plasma protein, including PTH, get oxidized. The problem is this is biologically inactive, and in CKD around 90% of the PTH is oxidized PTH. Now, whether the oxidized PTH actually exists, this is a paper published in JASN recently. They use mass spectrometry in identifying the PTH fragment. So in this study, they failed to detect any trace of oxidized PTH even in the sample of dialysis patient, calling into question the existence of oxidized PTH. Of course, we need more study in this aspect. Now we can see the different forms of PTH and the fragments, the inactive one getting accumulated in CKD. Coming to PTH assay, we have 3 generations. First generation is the radioimmunoassay which came in 1960, followed by the second generation one. Second and third generation are immunoradiometric assay. Second generation one came in 1987, which is otherwise called intact PTH assay. And third generation in 1999, which is called bioactive or biointact PTH assay. So in the first generation PTH assay, a single monoclonal antibody is used and it is directed against the C-terminal part. So the problem is it measures the biologically inactive C fragments. So then came the second generation. It is a sandwich immunoassay. There are 2 antibodies, one directed against the C-terminal part and the other against the N-terminal part. So here it is against the amino acid 12 to 24 in Allegro assay and 26 to 32 in Roche assay. So the limitation is they measure the non-184 PTH, that is 784 PTH fragment, which is inactive. So there is an overestimation of PTH by this assay in CKD. So to counter the pitfall of the second generation, then came the third generation. Again, this is a sandwich immunoassay. There are 2 antibodies, but here the N-terminal part is directed against the first 4 amino acid. So only full-length PTH is measured, fragments 784 not measured. So bioactive PTH assay result is around 50 to 70% of the second generation assay. Now, the problem with the third generation is it measures the modified form like oxidized and amino PTH. So these are the different technical aspects. We also have a non-oxidized PTH assay to find the non-oxidized PTH, however, it is not in clinical use. We have mass spectrometry assay, which is more specific and a promising candidate for reference measurement method of PTH. Now, this is the evolution of PTH assays from first generation to third generation, and what we are hoping now is a fourth generation assay where the modified forms are not measured and probably it is a mass spectrometry based assay. So every assay, every generation has limitation. Third generation, though it doesn't measure the carboxy fragment, but it is not widely available. So intact PTH assay is more available, more extensively validated and less expensive compared to the second generation assay. Now, there are a lot of variabilities in PTH assay. If you take the biological aspect, PTH concentration is higher in black race, higher with increasing age, higher in obese. Take the analytical aspects, there is so much variation. PTH is more stable in EDTA plasma, more stable at 4 degrees Celsius than room temperature. And if you take the blood sample from the central line, PTH value is higher than the peripheral line. So, lot of assay related variability is there in this measurement. So, what do we do in practice? We take the fasting sample because we can measure simultaneously the calcium level, test as early as possible after collection. If there is a delay, store at 4 degrees Celsius, and for transport, use cold chain. Now, standardization is a big challenge in PTH assay and no reference method currently. So, as KDIGO guidelines recommend, go for a trend in PTH monitoring rather than a single cutoff value. Intact PTH assay is the recommended one, and dialysis, the optimal level as per KDIGO is 2 to 9 times the upper limit of normal. And we know the biomarkers recommended by KDIGO are PTH and bone-specific ALP. Now, bone-specific ALP is having high specificity and sensitivity in assessing the bone turnover. The combination of PTH and bone-specific ALP is an effective tool. Of course, there can be variability. Increase in PTH with a low bone ALP means patient is having skeletal resistance to PTH. Now, it is having a longer half-life than PTH. So, the serum bone ALP could be a useful substitute in place of PTH to identify the bone turnover pattern. Now, there are several emerging biomarkers which has come to limelight in the recent years. There has been extensive study on the Wnt signaling pathway inhibitors. We have sclerostin and DICOF1. So, study has shown that sclerostin could be a new biomarker in CKD-MBD and it is a positive predictor of high turnover disease. We also have DKK1. One study done in non-dialysis patients showed both sclerostin and DKK1 are predictors of low turnover bone disease. And we have TRAP5B, marker of bone resorption. There is no renal clearance, so it is a better resorption marker than CTX. And this is a paper published last year identifying the role of genes as biomarkers. So the study found there are 5 key genes that have great potential as biomarkers and therapeutic targets in secondary hyperparathyroidism. Of course, this needs more research in this direction. So to conclude, of the available CKD-MBD biomarkers, the most widely used is PTH. KDIGO recommends usage of both PTH and bone ALP as biomarkers. Clinical interpretation of PTH measurement is challenging because there are several circulating fragments which are inactive, modified forms. PTH has a variability, lack of standardization. So rather than a single cutoff value, go for PTH trend monitoring. And mass spectrometry holds promise as a reference method but needs further optimization, and questions on the existence of oxidized PTH is there and that need further studies. Thank you.